Let's continue. We're going to finish up talking about our kinetics, and then once you finish this section, then we'll go into talking about some other kind of miscellaneous farm topics. So anyway, we're talking about metabolism. Remember the main enzyme system I wanted you guys to really kind of harp on? From enzymatic metabolism of drugs in the body, in the liver. It's 3 letters, 3 numbers. CYP 450, right? Remember CYP 450? So those are good enzyme system to remember, right? Because we metabolize a ton of drugs through CYP enzymes. Again, I'm not going to have you memorize each individual ones, but just know that there's going to be a lot of drug interactions that happen through those. Know that if I inhibit a CYP enzyme, that's going to have big drug interactions that can occur, because if I say, for instance, I have a drug that gets metabolized by, say, CYP3A4, right? And I inhibit that enzyme, what does it do you think, to levels of that drug? So the enzyme's not working as well because it's being inhibited. Drug level should go up or down? Should go up, right? Because again, the metabolism is being slowed because I'm inhibiting the enzyme, so less metabolism occurring, levels are going to go up, okay? However, I have something like an inducer that actually increases the number of enzymes available to metabolize that drug. Levels should go down, right? So those relationships are really important to keep in mind, because when we talk about drug interactions, you're going to see that that's going to cause all sorts of problems for your patients, right? Some of them can be pretty severe toxicities. In some cases, we actually use that to our benefit. Disease state that is very difficult to manage is HIV. Everyone familiar with HIV? Anyone know what it stands for? Immunodeficiency virus. So that's a disease state that used to require, I mean, dozens and dozens of pills you have to take every single day. And at some point they realized, well, wait a second, we have this one drug that's a really good CYP3A4 inhibitor, and we know that a lot of these other drugs that we would use to treat HIV go through that metabolism, but you're having to take this like 4 times a day or something. And they realized, well, what if I use this inhibitor to boost the levels of this other drug, and now all of a sudden they can take it maybe 1 time a day, right? So that's a case where we actually use a drug interaction to our benefit. So if you ever see someone taking a combination of pills like that for HIV, that's usually what it's for, so that way you actually boost the levels up, right? So that's where we're using it for our clinical benefit. In a lot of cases, those side effects occur because of that, due to increased levels. So again, we'll talk about it in much more detail later on, just an example to kind of show you how we use these sometimes to our benefits here. But anyway, looking at liver disease, again, if I have a diseased liver, one that's not functioning very well, you're going to find that you may have a harder time metabolizing drugs. So this can include things like alcoholic hepatitis. Say, for instance, if you have cirrhosis, if you have say drug-induced or viral hepatitis, all of these things can limit how well the liver is going to be able to metabolize drugs. And again, if I limit that, it's going to do what to my drug levels typically? That are drugs that are affected by that. They're going to go up. If the liver's working less well, you're going to find that the levels are going to go up typically. Okay. Okay. Some other things, you may find that with renal disease, you can have issues where, and a lot of this comes back to kind of blood flow. And what you find is when you have cases where patients are very like edematous, they have like things like congestive heart failure, like renal failure, you tend to find there's a lot of venous backflow, or there's a lot of venous stasis that occurs. A lot of blood flow is going to be kind of slowed within the venous side. And we know that normally the liver is receiving a lot of venous blood flow, right? That's where a lot of the drugs are coming in and actually get metabolized. If you slow that down, you're going to be slowing down how well drugs get metabolized, because the blood's just not getting delivered there quickly enough. Now, you may see this in cases where we have patients who have things like acute renal failure, diabetic nephropathy. This is a big thing we try to hold off in our patients who have diabetes, because this can be a non-reversible sort of injury that happens here. And I mentioned cardiac disease. In some cases, you have to alter your dose of your drug quite significantly in order to overcome some of these disease states. So, for instance, anyone ever heard of the drug lidocaine? Anyone know what that's used for? Yeah, it's an anesthetic. It's a local anesthetic. Sometimes you use it if you ever have like a laceration, you need to inject it into the site to do suturing and whatnot. But we use it systemically. We use it as a antiarrhythmic in some limited cases. But you find that with congestive heart failure, you're slowing down that blood flow getting to the liver. You actually have to cut your lidocaine dose in half. Otherwise, the levels are going to be twice as high essentially as they should be, and you can end up developing toxicity mainly in the CNS and in the heart as well. So again, these are things that you're going to have to be looking at. And when you're looking at a drug reference, you're going to find that it will have typical dosing, say a typical adult dosing for various disease states, different indications, and then you're going to have a section that says, okay, well, what do you do if a patient has renal failure? What do you do if a patient has hepatic failure? And you need to look at those if your patient has those disease states. or those insufficiencies, because if you don't, the dose is going to be way off and can end up leading to some pretty significant toxicities. And that's one of the big things we do whenever patients are being admitted to the hospital and you're doing like a med rec, right, going through all their medications, look at their organ function and determine, like, do I need to adjust these doses to account for their organ function? And I can tell you there's a lot of admissions that happen, especially in older adult patients, where they will be started on a drug at a particular dose, and then no one actually goes back through and checks their renal function. No one ever goes back through and checks their liver function. And so over time, that dose may have been effective at this point, may have been a good dose here, but 10 years down the road when their liver function is declined, that dose is now way too high. And if no one ever goes back and looks at it, guess what? They can come into the hospital for toxicity. And in some cases, I've seen some death related to that, right? So again, it can be very, very, something you really want to be cognizant of. Okay, you may find things like metabolism drug metabolism can be affected by different disease states. If you're hyperthyroid, what do you think that would do to drug metabolism? Probably speed it up a little bit, because again, hyperthyroidism is going to increase metabolism body-wide essentially. On the other hand, hypothyroidism is expected to be slowed down to some degree, absolutely. Genetic factors, we already talked a little bit about pharmacogenomics and how that can affect metabolism, whether or not you're actually expressing levels of enzymes in appropriate amounts, high amounts, low amounts, everything in between. And then diet and environmental factors. This is a huge thing you're going to be able to educate your patients on, because a lot of cases I can't really change the genetics of my patient, right? Not usually. Actually, there's some pretty interesting gene therapy we're actually doing over at Nemours for some congenital diseases. But beyond that, though, you can definitely affect their environment and their diet, right? So this is why education is important. Mention things like charcoal, cooked foods tend to induce some CYP enzymes, which may actually drive levels of their drugs down. May not be what you want. Things like grapefruit juice, you can tell them to avoid some of these things in order to avoid some pretty significant drug interactions. I kind of talked about that before already. Age and gender can affect this. We'll talk about special populations, specifically like neonatal and versus geriatric pharmacology, and we'll see that those their ability to metabolize drugs changes pretty drastically. And then again, anything decreasing blood flow to the liver was going to slow down metabolism. Okay, so moving on to drug elimination. So how do we actually get rid of it out of the body? Main organs are going to do this are going to be what? Kidneys, and then usually the liver, usually through the biliary tract, right? So it can spit out some of these things into the GI tract that then can be eliminated in the feces. Those are the two primary things. You may find some cases where we actually have like offloading of drugs in the respiratory tract, but again, it's pretty rare. Mainly the kidneys, and then to a lesser degree, going to be the feces and the biliary tract. So a lot of drugs tend to be freely filtered at the glomerulus. When we get into physio, talking about renal stuff, again, probably in, I think, section 3 or so, we'll get into much bigger detail on that. But you may find that lipid-soluble drugs tend to be reabsorbed very quickly, right? Because again, those renal tubules, they have that same phospholipid bilayers everywhere else. They find that lipid-soluble drugs can cross that very easily. So even though a drug may get filtered at the glomerulus, it can be reabsorbed pretty quickly, okay? So that happens in a lot of cases. One of the big things you want to note here, very similar to drug absorption, is that anything that's charged cannot cross that membrane again, right? So again, if I filter something out and the pH of the solution changes to where the molecule becomes charged, it's going to become more hydrophilic and it can't cross that membrane anymore, okay? Urine pH is normally somewhere between like 4.5, 5, sometimes up to 8 in some cases, but generally you're going to find somewhere like in a little bit more acidic range, right? Use 5 to 6 or so. And so I can actually use this clinically to help eliminate drugs more quickly. So for instance, if I have someone who overdoses on aspirin, take way too much aspirin, aspirin we mentioned is what, a weak acid or weak base? You remember? It's a weak acid, right? So again, it's acetylsalicylic acid, so it's weak acid. That's not a fact you have to memorize for the test, but just for our purposes here, we know it's a weak acid, okay? So we know that if I put a weak acid into a basic solution, what do you think it's going to put it into, a charged state or uncharged state? Remember, like dissolves like. It's going to be in a charged state, right? So if I put a weak acid into a more basic solution, it's going to become unprotonated, right? Because I'm losing a lot of hydrogen ions, and now it's in a charged state. So what I can do if I have someone who has an aspirin overdose and I need to get that aspirin out of the body more quickly, what I can actually do is alkalize the urine. So I can give them sodium bicarbonate to actually increase the pH of the urine to a point where that aspirin is going to become in a more charged state. So rather than reabsorb it, like it would in, say, a more acidic solution, a bigger proportion of it's going to be in that charged state, and it can just eliminate through the urine. And so you can see that. You can look at levels in your patient. You can do it, say every 2 hours, and you see it climb, and then it starts the alkalization of the urine, sodium bicarbonate, and all of a sudden it just starts to drop pretty precipitously, right? So that's one way I can actually help to eliminate drugs more quickly by altering the pH. That makes sense? So again, same factors, same Henderson-Hasselbalch equation, same thing is happening with absorption as it is with elimination in these cases. Okay, so I mentioned weak acids usually excreted faster in alkaline urine because again, there's less reabsorption occurring here. Weak bases are better excreted and more in acidic urine in those cases. Now, I mentioned that stomach trap or that pH trapping that can occur there, and again, this can occur anywhere. And we mentioned in the kidneys, but this can also occur in the breast milk, aqueous humor, prostatic secretions. By changing the pH when a molecule crosses that membrane, you can cause that trapping to occur based on the charge that it picks up. Okay. Why would I care about drugs getting into the breast milk? Yeah, because then the baby can be exposed to that as well, right? So again, that could be an inadvertent exposure to a child that may be inappropriate for them, depending on the drug. Okay. So I mentioned the aspirin overdose. By increasing the pH of the urine, I can increase the amount of charged aspirin that's there. I can decrease the amount of reabsorption it has, and then they eliminate it that much faster. Okay, so we talk about clearance. Clearance is basically the sum of all the different ways that we try to get rid of drugs out of the body. And so clearance can be including several different pathways. We can include the renal, include the liver, maybe there's other pathways like say breathing off in the respiratory tract, whatever it happens to be. I can include all that together. And so basically I have a clearance total, okay? And again, by changing and depending on the drug, some drugs are only renally eliminated. Some of them will go through the liver and then a portion of it go through the kidneys. It just depends on the drug. But by combining all those together, I can figure out what my total clearance is. And again, by altering any of these, and I may potentially alter pretty significantly how well I clear that drug from the body. So this is a very important factor determining drug concentration. So for instance, if I decrease the clearance of a drug out of the body, what do you think it's going to do to the concentration of that drug? Should increase it, right? So again, most of this is pretty common sense regarding to if I decrease the amount that's leaving the body, more of it's in the body, so the level should end up going up in those cases there. Normally, we're going to estimate renal elimination based on creatinine clearance. Okay, so if everyone's familiar with creatinine, talked about like in Clin Lab, possibly. Maybe it comes on a Chem 7. Normally you see like your electrolytes, you see your glucose. One of the big things we look at is also going to be their creatinine. That tells us, and anyone know where creatinine comes from? Actually comes from muscle breakdown, right? So again, you have a little bit of muscle breakdown that occurs, throughout the day. You're going to generate a certain amount of creatinine. We can use that as a surrogate marker to determine how much filtration is actually occurring at the glomerulus, how much actual clearance is going to be occurring here. Basically, creatinine is a product of muscle metabolism that occurs at a pretty constant rate. So we know it doesn't really change that much. And by using that serum creatinine, and a normal one would be somewhere between like 0.6 to 1.2 for most adult patients, healthy adult patients, we can use this in an equation to estimate what our creatinine clearance is going to be. Okay, so this is a surrogate for what the GFR would be, like glomerular filtration rate. In some cases, you could actually get a more accurate estimate by doing a 24-hour urine collection. How easy is it to do a 24-hour urine collection? The pain in the butt. You want to do that, right? So again, if I can use just a simple lab value, if I can just check the blood to see what the creatinine is, plug in a few variables, and then get a good surrogate number, that's going to be a lot better, a lot more convenient for us. And that's typically what you do in the clinical realm. So just to give you an idea, there's many different equations that are out there. Now, I don't want you to memorize these equations specifically, but I do want you to kind of note what different variables are going to be going into determining what a patient's estimated creatinine clearance is going to be. Okay, the most common one you're going to run into for most adult patients is going to be the Cockcroft-Gault equation. And so what you notice here is that our creatinine clearance, and again, this is just the renal clearance, is going to be equal to, and basically some of these variables have already been figured out. Anyone know how they determine these kind of equations? Basically what they do is they take a big study, or hopefully it's a big study, a lot of people. We'll talk about this in MP Bio a little bit next semester. But they try to determine what their actual creatinine clearance is, and they make an equation to kind of backfit that, right? They make a model essentially to try to figure out how to best estimate what these are. So again, there's going to be deficiencies in all of these equations. Not every one of them is going to work perfectly in every single patient, which is why we have a lot of different ones that are out there. So for instance, for pediatrics, I cannot use this equation for pediatrics because it has not been validated in that population. We have a different equation that we're going to use. So just know there's a little bit different use for every one of them. But the factors that are going to go into it are going to be pretty universal for the most part. So you're going to notice here the creatinine clearance is equal to 140 minus our age. So what do you think happens with age? As age increases, what do you think that does to our creatinine clearance? Do you think kidneys miraculously improve as they turn 70, 80, 90 years old? No, we know there's going to be a functional decline. We know that kidney function gets worse over time, just like every other function gets worse. I know as soon as I hit 30, everything started going downhill. It was bad news, right? Things are creaking, popping, like they haven't been before. But usually when you're at 60, 70, 80, that's when things are really starting to go downhill, right? So factoring in age is really important here. You're going to factor in their weight as well. Why do you think weight's important?
The heavier you are, you can, I guess, more deposits of
Well, so this is just using creatinine to help us estimate the renal functions. We're not looking specifically at the drugs yet. However, if you have a heavier person, what do you think about their muscle mass? Do you think it would be more or less than someone who is smaller? Again, within reason, right? So again, we're not talking about someone who's like 400 or 500 pounds, which we see those patients occasionally, but do you think they would probably have more muscle mass, right? So again, more muscle mass, you should be producing more creatinine. So again, that's why we're factoring that in there. So again, we're going to factor in their weight. So typically, if the weight goes up, you would expect to see creatinine clearance. It tends to go up as well, yeah. Yes, sir.
I would say, what about like for fat versus muscle? That's another impact.
That's a great question. Absolutely, that does have a big impact, and I'll talk about that in just a second. So anyway, so we're noticing here, so the age goes up. What do you think that does to creatinine clearance based on this? It should decrease, right? Because again, 140 minus their age, as they get older, that number should get smaller, right? So again, as age goes up, creatinine clearance tends to go down. As weight goes up, typically creatinine clearance tends to go up as well. Again, we'll see that's within reason. And then you're going to be dividing it by the 72 times their serum creatinine. So serum creatinine is being in the denominator. So if I increase the serum creatinine, what should that do to my creatinine clearance? So as the denominator gets bigger, my creatinine clearance gets smaller, right? So again, if I have someone who has a creatinine of 4, they're going to have a lot worse renal function than someone who has a creatinine of 1. And that kind of makes sense because I know if their blood is holding on to that creatinine because they're not clearing it through the kidneys, that shows that their kidneys are not functioning that well, right? So again, I was looking at an EOR note for one of the students on rotations. They had someone who was coming in for rhabdomyolysis, and their creatinine is a 23-year-old. And I said a normal serum creatinine for a patient like that's 1. His creatinine was 4. That's very abnormal. That's very indicative of a really significant kidney injury. So even small changes there in that denominator can have some pretty big effects, right? So again, that's what we're going to be looking at there. And you notice here we're multiplying it by 0.85 if we're dealing with a female patient. What do you think that is? Typically, yeah, on a kilogram per kilogram basis, and again, the weight's always going to be in kilogram for these equations here, so kind of get used to dealing with kilograms. You're going to find that typically women have more adipose tissue, less muscle mass than guys do. Are there exceptions to that rule? Absolutely. But and again, when they did this study back in the day, this is what they determined to be kind of the most accurate model. So again, this may not apply. If this was done back in the 70s, may not apply to this 2000 plus sort of population. So maybe that's something they're going to revisit one day. Who knows? But this is what we work with. This is what we've been using for decades now. Now your question was, well, what if you're dealing with someone who has like really kind of extremes of weight, right? They have a ton of adipose tissue. I know they're not really, if you have someone who weighs 300 pounds, yeah, sure, they could be all muscle. More likely than not, though, they tend to be a little bit heavier. They usually have a lot more adipose tissue. There's ways that we can get around that, and that's what we call an adjusted body weight. Again, that's going to kind of outside of our scope for right now, but basically what we'll do is that everyone based on their height has an ideal body weight, right? So we can take what their ideal should be, figure out what their actual weight is, and then kind of get kind of an in-between sort of number there. We kind of get an adjusted body weight that we can use. Again, it's not perfect. We're still kind of fudging the numbers a little bit, but it gives us a better estimate than if we use like, someone who's 500 pounds, putting that in there, it's going to look like they have awesome creatinine clearance when probably a lot of their choices that led them to be 500 pounds in the first place have not been too good on the kidneys, right? So they're diabetic, and if they have hypertension, all this other stuff, like that's probably been hitting the kidneys pretty hard, right? So again, it's one of those things where, again, this is all within reason. There are ways to kind of get around those kind of extremes in weight there. Okay. So that kind of makes sense. The different variables are factoring into how we determine creatinine clearance. I don't want you to memorize this number because, again, if you put a gun to my head, I would probably need to go look it up anyway. Just Google how to do Cockcroft-Galton and get that number. Yes, sir.
Did you say with a low creatinine clearance, that's indicative of like glomerular like dysfunction?
Well, it could just mean that you are either not filtering well. There could be several different things that are going on, but basically means that what is in the blood is not getting filtered very effectively, essentially, right? So the glomerular filtration rate is going down, essentially, right? Makes sense. Yes. Oh,
yeah.
You follow?
And if it's high, would that mean that it's just?
It means it's functioning very well. So you can have patients who have a creatinine clearance of, say something like, 100, 200 mLs, per minute or something like that, and that's totally fine. I'll show you some numbers here, kind of what normal values are a little bit later. Yes, ma'am.
You said that your serum creatinine, and then as that goes up, then creatinine clearance goes down?
Yep, because in that denominator there. Yep, absolutely. Anyway, just another example of this one was done. This is the modification of diet and renal disease equation. This is one they did in some older patients, and actually, if you notice here, they still have a value to factor in if the patient is female. They're still looking at serum creatinine, still looking at age. Again, when they did their study, their model was different based, and this is the equation they used to get the most accurate estimates. And here they're looking at patients who were black. They were able to factor in a different factor here. Based on this, what would you assume about black patients? they probably have a little bit better creatinine clearance than, say, white patients, at least in this study when they perform that, because they're multiplying by 1.2 rather than trying to multiply by a decimal there. Anyway, different formulations are out there, but generally you're going to find the same factors that go in. Usually the age is going to go in, usually the weight's going to go in, and usually the serum creatinine. Those are the main factors you're going to look at there. Okay. Now, of course, there are other cases where you find there's some deficiencies here. For instance, if I have someone who has an amputation, say they have a bilateral amputation of the legs, that's a whole lot less creatinine they have to produce, less muscle mass to produce creatinine. And so they tend to have issues where you're overestimating their renal function. So there's always some caveats there, but you have to look at each patient individually, essentially. So normal creatinine clearance for, say, an average male patient would be something like 120 mLs per minute per 1.73 meters squared. Again, that's just body surface area. The range can be pretty wide there. Once you start getting down much below that, so starting getting into like the 60s, the 30s, the 10s, that's when you're starting to see pretty significant renal dysfunction occurring there. In some cases, can patients have zero serum creatinine clearance? Absolutely, you can have fulminant hepatic renal failure, and where they're filtering nothing at all, basically. They're anuric, they're not producing any urine, and then at that point, you have to put them on dialysis, or someone has to put them on dialysis. Female patients, again, because they're producing less creatinine, usually they're going to have a little bit lower average creatinine clearance there. Okay, so the reason why we cover this, by looking at clearance, by looking at the volume of distribution, you guys remember what volume of distribution was? Yeah, how widely distributed drug goes into the body, right? And again, it's a theoretical number, but helps us to remember, to kind of guide us like, well, does it go really far into the tissues? Does it just stay in the blood? Where does it go? That helps to determine what the half-life is. And we mentioned half-life before. What is half-life? How long it takes to get a 50% reduction in a drug, right? We talked about that being a factor with certain hormones. Hormones can have different half-lives. Drugs all have a half-life associated with them as well, right? Some of them can be seconds long, some of them can be months long, right? It just depends on the drug you're dealing with. But basically, clearance is going to determine how much drug we're actually eliminating per unit of time. Okay, so it's telling how quickly we're getting rid of the drug that's in the blood, right? Because again, the drug has to be within the blood to get to the kidneys to be filtered to be eliminated, right? Or to go to the liver to be metabolized. Volume of distribution determines how much volume has to actually be cleared. So for instance, if I have something that has a very low volume of distribution, all of it stays within the bloodstream, do you think that has an easier time being cleared or harder time? It's a lot easier because it's all right there in the blood. It doesn't have to be leached out from the tissue. However, if I have something that's a very large volume of distribution that's sitting out there in the adipose tissue, it takes time for that all kind of leach back into the systemic circulation before it can be eliminated, right? For instance, like I mentioned with THC, remember I talked about that example, how long you can stay positive in some cases. If you have a really big tissue distribution of THC, it can be potentially weeks to months before you're actually clear of that, before you actually get rid of it all out of the urine. On the other hand, something like cocaine may only stay positive for like 2 or 3 days. Not that I'm advocating trying to time your urine drug screens with drug use or anything. Cocaine's very bad. However, that only sits around for 2 or 3 days because it has, the volume distribution is a lot lower for that. It sticks around the central circulation. You clear it very quickly, right? So again, it all goes back to what the volume distribution is, what the clearance of the drug is going to be in total, right? Both of those together will give us an idea of how long the half-life is going to be, right? So again, a longer half-life, usually, what do you think that would mean? Slower clearance, right, means the drug's sticking around for a lot longer, right, versus something that's a very short half-life, gets cleared away very quickly, right? So again, some things we're going to be looking at. Some drugs have very long half-lives, some drugs have very short half-lives. And what do you think that means for something like drug dosing? Like for something that has a very long half-life, how often do you think I would have to dose that? Yeah, not as often. So maybe every day, right? Maybe I can get away with everyday dosing of a drug versus something that's a very short half-life. Maybe I have to give something 4 up to 6 times a day. What do you think patients have an easier time taking? 1 pill a day or 6 pills a day? 1 pill a day, right? So again, this goes back to compliance. So if I have a drug that I have to give frequently because it's a short half-life, maybe that's not a good option for my patient because they don't want to take something 4 to 6 times a day, or if they have memory impairment, or if they have any other reasons they can't take it reasonably. So again, this is all very important. It goes right back to our patients, as we'll see as we go along. The clearance also helps us to determine what the steady state plasma level is going to be of these drugs. Okay, and what steady state is? If you had to guess what it is.
Like an equilibrium?
Yeah, basically it's an equilibrium, right? So we're going to see that when we get to steady state, basically what it's going to be is that the amount of drug I'm putting into the system equals the amount of drug that is exiting the system for a given period of time, and that should have a good average concentration of drug within the body. That's what our steady state plasma level is going to be. So we'll go into more detail with that. So some other things to note about elimination here. We have what we call first order elimination and zero order elimination. Any Star Wars fans? This has nothing to do with that first order, but you're going to find that with first order elimination, this is basically we're going to be metabolizing, I'll show you some graphs here to make this more clear, but metabolizing a constant percentage of drug per unit of time. So maybe I'm doing 20% of that drug every hour, okay, or maybe I'm doing 50%, whatever it happens to be. What you're going to notice is going to be proportional to concentration. So for instance, if I have a level in the blood, say of 10 milligrams per liter, and I metabolize, say 20% during that hour, after an hour I should have how much left? The level should be 8, right? Because again, I metabolize off 20%. Okay, that makes sense. However, on the other hand, if I were to start off with a level of 100 milligrams per liter, and I still am metabolizing 20% per hour, how much drug would I have left after that hour? The concentration be? It would be 80, right? Because again, I'm still metabolizing off 20%, so it would be 80 at that point. So you notice if that level's higher, more drug is being metabolized during that period, okay? So it's proportional to the actual concentration. So the more drug gets metabolized, the higher the level is at that point, right? Because it's always going to be a constant percentage per unit of time. And I'll show you some graphs that will, again, make that more clear. Most drugs end up following first order kinetics, okay? And this is very important to understand when we're talking about steady states and things like that later on. We also have zero order kinetics, and this is usually going to be for drugs that saturate the enzymes. And we mentioned that when you saturate an enzyme, guess what? Even if I give more drug, I can't metabolize it any faster because the enzymes are working as hard as they can. There's only so much they can do, right? And so in this case, you're going to find this is going to metabolize a certain amount of drug per unit of time. I mentioned ethanol being a good example of this because, again, when you start to saturate those enzymes within the liver, you're going to find that even if I increase the level of alcohol, say to 2 times normal, 4 times normal, 10 times normal, I don't metabolize it any quicker. It just means the patient's drunker and they're going to be sitting there for longer until they sober up because I can only metabolize, say, on average, 20 milligrams per deciliter per hour. Okay, even if I put more in the system, doesn't do anything, doesn't speed up metabolism at all. That's called zero order kinetics. Okay. So if I were to look at this on a graph, you would see, again, drug concentration on the y-axis, time on the x-axis. For something that's zero order, again, I'm metabolizing the same amount of drug per unit of time. So this would be a straight line if you're looking at this. Versus something that would be first order kinetics, again, I'm doing a certain percentage per unit of time. It usually will see that the higher the concentration is, what do you notice about the slope of this curve? It's a lot steeper. I'm metabolizing a lot more drug early on, and then as the levels get lower and lower and lower, what do you notice? Gets a lot more shallow at that point because there's less drug around. I'm still metabolizing the same percentage, so it's going to become a lot less drug being metabolized during that period of time. Make sense? So looking at first order kinetics, again, renal clearance of drugs can affect this quite significantly. So normally what you're going to find is that with clearance is going to be able to basically equal the rate of administration or the rate of how much drug I'm putting in divided by the drug concentration itself. Okay. And so, and again, I'm not going to have you do too much math on the test here. I'll give you some examples during the review later on, but the concepts here are what I want you to really key in for the most part, right? So again, how do I determine what the rate of my administration is? How do I determine how much drug I'm putting in? Well, basically, it's going to be the dose I'm giving divided by the interval, right? When I say interval, what do you think that means? Good. So when you say Q12, Q6, what does Q mean? Every. Good. So again, if I'm giving something Q6, that means I'm giving it every 6. Now you should specify. You can say Q6, but I may say, well, Q6 days, Q6 months, Q6 minutes. What do you want, right? Q6 ducks? Who knows? I will harp on this quite a bit because, again, medication safety is a huge, huge issue in and outside of the hospital. You need to be specific whenever you're writing orders or you're saying things because, you know, you can have cases where you're working in the ER as a patient coding and the doc says, I need an amp of calcium. So, well, what the heck does that even mean? Do you want calcium gluconate? Do you want calcium chloride? How much is an amp? Do you want a gram? Like, you need a dose, right? These are things you need to be really clear about. So when you say Q6, a lot of people will assume Q6 hours. However, you want to be specific and always say Q6 hours or every 6 hours, right? You know, we can really confuse that. But yes, that is absolutely right. So again, it could be Q12, Q24, Q6, Q1. Depends on the interval. It depends on the drug you're going to be administering, right? So again, that's what interval is referring to there. Okay. And so just so you know, when we're talking about intervals, when I say to increase the interval, what do you think that means? I say increase the interval means I'm giving the drug less often. So if I'm going from Q6 hours to Q12 hours, that would be increasing the interval, but it also means I'm giving the drug less frequently. Okay? If I'm increasing the interval, that should mean I'm giving it less frequently. If I'm decreasing the interval, I'm going, say, from Q6 to Q3, then I'm giving it more often, right? So again, that would be decreasing the interval in those cases there, right? Okay. So again, just know there's going to be a proportional relationship between the drug concentration and the clearance. The more drug I put into the system, the more it's going to be clearing during that unit of time. This is really going for first order kinetics specifically. So imagine I was putting an amount of drug into the body. I put 1,000 milligrams. I didn't put my units on here, so again, this could be rife for error. It could be micrograms, could be milligrams, whatever. But anyway, let's assume it's milligrams. And I'm looking at time here. So again, I'm looking at hour 0. I'm putting in 1,000 milligrams into the body. I gave it via IV push right into the system, right? So again, I know IV has what bioavailability? 100%, right? Good. So looking at this with first order kinetics, at the first hour, let's say I metabolize off 150 milligrams, okay? So that's basically 15% of that drug got metabolized off just during that first hour, okay? During that second hour, what do you notice about the amount of drug eliminated? It's less, right? As the concentration goes down, less drug is being metabolized. Now it's still 15%, which means there's less drug around to have been metabolized in the first place. As it go hour to hour to hour, you're gonna notice that this amount gets smaller and smaller, until eventually you're metabolizing very minuscule amounts of the drug, because again, most of it's almost out of the system at that point, right? So again, it's always gonna be by 15% per hour in this particular example. Okay, that's first order kinetics. Again, another graph kind of showing you what this looks like. So I start off with 100% of the drug around, and again, at this point, what would you call this time interval here? This would be a half-life, right? Because then there's 50% of the drug being eliminated here, right? And so you can see here on the x-axis is the half-lives they're going along. But again, it should be half every single time. So again, by the time I've reached 2 hours, I should have basically 25% of the drug around that I started with after 2 hours, right? Because again, it's been 2 half-lives. Kind of knowing that that sort of relationship is important there. By the time I'm at 3 half-lives, should be down to 12.5% where I was, then 6.25, then 3.12. So again, it gets incrementally smaller as you get more half-lives away from where you initially started. Okay, so the way that we can, again, this is as complicated as I'm probably going to get for this stuff here, but basically for every drug, you're going to develop what we call an elimination constant. So this is Ke. And so essentially what we're going to do, and I'll show you how this is going to help us to determine what a half-life for a drug is. Again, I'm not going to make you calculate, the natural log of anything on the test. That would be especially mean. I couldn't do that without a calculator at least. But basically, Ke just tells us what kind of fraction of drug is eliminated per unit of time. So per hour, am I eliminating 15%? Am I eliminating 20%? What is it? And we can measure this by actually taking the slope of the line. And so by basically how we end up determining that is by looking at the natural log of the peak divided by the trough. And when I say peak, what does that mean? The max concentration I reach, and then the trough would be what? Yeah, it'd be the lowest level I'm going to be measuring there, right? So I can measure this peak right here versus this trough, and then by dividing that and then factoring the time difference there, so how many hours it happen to be, then I can figure out what the Ke is. I can figure out the percentage of drug per hour that I'm actually eliminating. So what I could also do, though, is I can substitute this information in here, and I can make Ke equal the clearance divided by the volume distribution. So based on this, if I increase the clearance, if I increase this variable, what do you think it does to the Ke? It should increase as well, right? So that percentage of drug goes up as I increase my clearance. Similarly, if I were to decrease clearance, that does what to the Ke? Should decrease it, right? So for instance, if I had a patient who had sudden onset acute renal failure and their clearance went down pretty dramatically, you'd find the Ke would also go down pretty dramatically as well, right? It's a proportional relationship there. On the other hand, though, with volume distribution, if I were to say, for instance, increase the volume distribution, that would do what to the Ke? That would decrease it. This is an inverse relationship you're going to see here. So as volume distribution goes up, say for instance, I have someone who develops ascites. You know what ascites is? Yeah, there's a lot of fluid buildup. You usually see it with like liver patients and things like that. But basically, they're going to have all this fluid there. If I have like a hydrophilic medication that likes to partition into water, it's all going to partition there. The volume distribution goes up. That means less of it's in the blood to actually get filtered by the kidneys. Now my Ke is going to go down in that case. My volume distribution went up. Okay, that's in the denominator. So those relationships are good to keep in mind because again, we have to evaluate our patients. Like, well, what's their volume distribution? Has it changed dramatically? We see it change significantly. If a patient has significant dehydration due to gastroenteritis, diarrhea, or if they are a trauma patient, like a burn patient especially, do they have edema? Things like that all can change the volume distribution for your drugs. You have to keep that in mind and keep in mind how it's going to affect the clearance of the drug as well. Okay. Okay, so I mentioned the half-life is going to be the time it takes for the drug's concentration to drop by half. So say, for instance, I have drug A, and say the concentration at 4 p.m. is 20 mics per ml. And let's say the concentration is then 10 mics per ml at 8 p.m. I took 2 levels. My nurse drew those levels, and I got them back from the lab. What do you think the half-life is of this drug? 4 hours, perfect, right? So again, we do these calculations all the time when we're measuring levels of drug in the patient's blood. So say, for instance, if I were to check that level again at, say, midnight, what do you think it would be? It would be 5, right? Because again, assuming nothing happened to the patient during that time, they should be metabolizing the same amount per unit of time. So again, because this is all first order kinetics, it should be about 5. Okay, and then if I were to do it, say at 4 a.m., it should be 2.5, right? Very simple math we're doing here, right? So again, just using a half-life, you know, you're getting 50% drug eliminated during that time. How about, let's say a drug concentration of drug B is 40 mics per ml at 8 a.m., and then it's going to be 10 at 4 p.m. What can you determine there? What's the half-life?
4 hours.
Still 4 hours. Why is that?
Because the half-life was 20 at 12.
Yeah, so you can determine how many half-lives have occurred here. So I go by half, so 40 to 20, and then from 20 to 10, I can assume 2 half-lives have occurred, and by taking that half-life and divided by the time, right, so I know it's been 8 hours, then I can say, okay, well, you know, figure out what that is, 4-hour half-life essentially, right? So we do this, again, very frequently. We have calculations that can help us to do this, again, when you have kind of more, not round numbers like this, but if I were to put something like this on the test, it would be very round numbers, easy stuff you can do in your head or on the scratch paper, okay? Okay, and again, 50% of the drug being eliminated. As long as you can determine how many half-lives have occurred with the drug concentrations, you can determine what the half-life is going to be based on that difference in time, essentially. Okay, again, as I mentioned, you can find half-lives to be extremely variable depending on the drug you're dealing with. So a good one called adenosine, or my emergency medicine people. What do we use adenosine for? SVT is supraventricular tachycardia. You ever seen adenosine given?
Yep.
Super cool, right? What does it do to the heart? Stops it. Your patient flatlines for a second. Super cool if you ever get a chance to see it during rotations. Basically, you have a continuous EKG going on, and you push it really fast, and all of a sudden, patient's heart's probably going like 160, 180 beats a minute, and all of a sudden it stops for a second, and everyone's like, please come back. And then they come back, and okay, good. Very cool drug. But anyway, it's a very short half-life. You have to give it super, super quick because half-life is less than 10 seconds. So if I put it into a peripheral vein, I need to make sure I push that with enough fluid to get it up to the heart as quickly as I can, because otherwise it's going to degrade by the time it gets to the heart. It doesn't work, right? So a lot of times I'll run into problems where the patient said, well, they didn't respond to the first dose. I had to give a second bigger dose. And I was like, well, did you actually give it appropriately? And they're like, oh, I only just pushed it slow. And they're like, okay, that's the reason why it didn't work in the first place, because the half-life is so short. On the other hand, though, a drug called amiodarone. What is amiodarone for? Anyone know? Do you know what you use amiodarone for? They'd put you on the spot. So this is another big one we use for other arrhythmias as well, usually like ventricular arrhythmias. So when you guys talk about ACLS, advanced cardiac life support, amiodarone is going to be a big drug you're going to use there for patients in like VFib, VTAC. You can sometimes use it for like atrial fibrillation, so a lot of different indications here. Again, not important to memorize that now, but the point I'm trying to make here has a very, very long half-life, anywhere between 26 to 107 days. Very long. And again, when I'm saying, like, you know, in medicine, do you want to be have that high degree of variability? You want to say, well, I don't know, it's probably between 26 and 107 days. You don't sound too confident when you say something like that, right? But it can depend on the patient, depend on the liver function, depends on several things. But that's important because when we're talking about getting to a steady state level, we're going to find that half-life is going to be very, very important to determining how quickly we can get to steady state. And again, that's going to be the average concentration of drug in the body. Okay, so how can you calculate half-life? If you needed to, basically what you can do, if you know the KE of the drug, right? And again, some of this is going to be based off of like population kinetics, where you can kind of take what the average population value is and extrapolate it back to your patient. Basically what I can do is take 0.693 divided by KE. I'm not going to have you memorize that, but just know another way that I could do this by substituting in what we know from previously. We know that clearance divided by VD can be substituted in for KE. Basically, I can see that, okay, my half-life is going to equal this 0.693 times VD divided by clearance. So going in and looking at this, if I increase volume of distribution, what do you think it does to the half-life? Increases the half-life, right? And what does that mean for that elimination of the drug? It's slowing down, right? So again, this KE has that same relationship here where we're seeing the volume of distribution. As it went up, it was actually slowing down. The KE is lowering it. Same thing here. It's actually extending out our half-life. It's taking longer for that drug to go down by 50%, okay? The other thing we'll probably see that comes up more often clinically is the clearance. So because this is in the denominator, if clearance goes down, what do you notice about the half-life? It increases, which means, again, it can take longer for that drug to be eliminated from the body. Okay. Again, usually concentrations rise, and you may be more likely to see toxicity. So these are good factors to keep in mind. That if my clearance of the drug goes down, half-life is going to go up. If my clearance improves, half-life should go down, and I should be eliminating that drug more quickly. Okay, so keep these relationships in mind. All right, so for instance, let's see, we kind of already talked about these relationships, but keep these in mind because, again, this might be good test questions that come up. I say, hey, for instance, you know, a patient is taking a drug that is only renally eliminated, normally has a half-life of, say, 5 hours, and now the renal function is nothing, is 0. What would you expect the half-life to be now. And so I might have like say 1 hour, 2 hours, 5 hours, and like say 20 hours. And you assume reasonably that 20 hours would be the only one that's possible, because as the clearance goes down, half-life should get longer, right? Because again, it takes longer to get rid of the drug, so it takes longer for that 50% decrease to occur. Okay? All right. So steady state, we mentioned, is going to be the rate, or that equilibrium point, where basically the amount of drug I'm putting into the system is equal to the drug eliminated from the system. So for instance, if I give a drug 1 time a day, if I give 100 milligrams of the drug a day, I should be getting 100 milligrams of the drug out at that point when I'm actually at steady state. And it takes time to get to steady state, right? And at that point, you're going to have an average concentration that the body's basically staying at. And I'll show you some graphs of this to show you what it looks like in a second here. But basically, again, with first order kinetics, I know that as the level goes up, what does my clearance do? Or the, because again, first order kinetics, I always know that the percentage of drug is going to be the same metabolized per unit of time. So if I increase the concentration, the clearance should also increase, right? Again, this should be metabolizing more drug, essentially, right? So as that goes up, I should get to a point where there's actually an equilibrium point where the amount I'm putting in is equal to the amount that's actually being eliminated per day or per hour, whatever it happens to be. And so basically what I can do is I can actually calculate this. Again, I probably won't actually calculate this specifically on the test, but at steady state, basically this concentration at steady state, that's what CSS means, will equal the dose divided by the clearance times the dosing interval. Right, and I mentioned that dosing intervals is how often we're giving the drug, whether it be Q24 hours, Q12 hours, Q6 hours, whatever it happens to be. So, looking at this, we would see that if I give a bigger dose, what do you think that does to my steady state concentration? Should increase, right? So that makes pretty logical sense. The average concentration of the body should increase if I give a bigger dose. Okay, that makes sense. If clearance goes down, what does that do to my CSS? That should increase it as well, right? Because again, I'm clearing it to a lesser degree, so those levels should start to increase as well. If my renal function takes a hit, then I should see those levels start to climb up. And then the dosing interval is also going to have a factor here as well. So again, if I'm giving it a longer interval, say for instance I'm giving it say Q24 hours versus say Q12 hours, which one do you think would have a higher average steady state concentration? We'll look at some examples of this in just a second, but there's some ways we can overcome this. So I'll show you what that looks like in just a minute. So kind of keep that on the back of your minds. Okay, so again, looking at dose, we saw that. So again, and then increasing the dosing interval usually is going to end up lowering, as we'll see, our steady state concentration typically. So I'm giving something Q24 hours, I'm going to have a lower steady state concentration if I were to give it Q12 hours. And I'll show you some graphs that actually shows that how that actually works out. A good number to remember is it takes roughly 4 to 5 half-lives to get to steady state levels. Okay, so imagine something like amiodarone has something like let's say a 50-day half-life. How long is it going to take to get steady state? Like 200, 250 days. That takes a long time to get up to that average concentration, right? I'm going to show you a way we can actually get around that, but no one wants to wait 2/3 of a year to get their drugs up to steady state concentrations, because that's when it's going to be most effective, essentially. So we're going to find some ways to actually get around that a little bit later as well. Okay, so again, looking at, and again, which is not yellow, but anyway, looking at the input rate is going to equal the elimination. Typically, if I were to give a drug, if you say via continuous infusion, so I'm giving it in a vein, I know that's 100% bioavailability, I'm giving it at a continuous rate. Normally what you would see with a steady state is that as the levels start to climb up, what do you notice here? The plateau effect, right? Because what's happening when I hit this plateau? Your steady state, which means the amount I'm infusing into the body is the same as what? What's leaving the body as well, right? So again, every time, if I were to change this dose, say for instance I give a larger dose, I was to increase the rate of that infusion, what do you think it would do to the steady state concentration? If I increase the dose, you'd expect the concentration to go up. So if, for instance, it may go something like this. If I were to increase the amount of drug I'm giving, I increase that rate of the infusion, right? More drug in means a higher concentration in steady state. On the other hand, if I were to give, say, a lower rate, or to slow down that infusion, what do you think would happen? Steady state would go down, right? Again, it's kind of makes sense based on if I'm putting less drug into the system, metabolizing less of it, I should have a lower steady state concentration there, right? Okay.
So can you also say that that's like the Emax of the drug at that drug's concentration?
That would be not necessarily the Emax, because again, Emax has to do with like determining the maximum effect that you could get out of a drug. This is simply the maximum level that we are trying to achieve with that drug on an average sort of basis there, right? So again, I could keep driving this dose up higher and higher and get a steady state that's huge. However, that might be the point where as I get close to the Emax, maybe I start to have a bunch of toxicity. I wouldn't want that to occur. But this may be like your Cmax. You may see that your concentration max is another variable you might see occasionally with some of this farm stuff, right? But yeah, not the same as the Emax in those cases. So let me show you a different way we could also do this, because again, how often am I giving drugs via continuous infusion? Do you see a lot of patients at home with like an IV pump that's like infusing drugs continuously? Not frequently, right? Some patients, yes, but not frequently. More often, I'm giving drugs intermittently, right? Intermittently just means what? Yeah, kind of throughout the day or giving it every so often, right? So even if I'm giving something every 24 hours, that still can be considered intermittent administration. It's not continuous at that point. So the same thing can happen here. Imagine I'm giving a drug, and you can see here, the blue line is going to be if I was giving it via like continuous infusion versus the red line here if I was giving something less frequent. So let's say, per half-life, I'm giving a drug dose every time. So what do you notice with these levels here? Notice how they're increasing, right? So that's as I administer a dose, you're going to see the concentration go up. But then what do you notice here at this point? Yeah, so it's going to start to go back down until I get the next dose, right? So again, it's going to go up. You're going to see all these peaks and valleys occur as I start to give more and more doses. So what you see is that even though if I'm giving a drug intermittently, I'm going to have peaks and valleys, the average concentration is what I'm going to call my steady state, right? So again, I'm averaging out the peak versus the trough, and I should be getting the average steady state there, okay? So again, more frequently than not, you're going to find that you're going to have intermittent administration of drugs, and that by altering the dose and altering the frequency, I can achieve the same steady state levels, okay? So this graph shows a good example of that. So let's say, for instance, I'm giving a drug either via continuous infusion, which is this dark line here, or I'm giving a smaller dose more frequently, so my interval is smaller, right? So this one's being given, say, every 8 hours. So you can see how you get a large increase. This would be something like a IV administration. You give like an IV push. Notice the level drops, spikes up really quickly, and then it goes back down. And then this would be a larger dose I'm giving, say, every 24 hours. Okay. So what do you notice about the differences between, say, the Q8-hour administration versus the Q24-hour administration? Higher peaks for because I'm giving a bigger dose for these guys here, and also do you see? Lower troughs, so bigger peaks, lower troughs. However, the average concentration is identical, right? It's the same no matter what. So again, I can factor in these sort of things. So what you may find for some drugs is that, yeah, I could give a drug every 24 hours and get that same steady state concentration. However, imagine, for instance, that when I get to this high of a level, what if that's when I start to develop toxicity? Maybe I don't want that high of a peak. Maybe I have to give a drug at a smaller dose but more frequently in order to make sure that I keep a tighter range on those peaks and troughs to make sure that I don't get toxicity but I still maintain the efficacy, right? Because again, that steady state concentration should be where you're getting efficacy out of that drug essentially, okay? Similarly, if you imagine, for instance, certain antibiotics, right? Antibiotics are meant to do what? Kill bacteria, right? So if you will find that in certain types of bacteria, certain types of drugs, if you drop below a certain concentration, the bacteria start to replicate again. They start to reproduce again. And so by keeping up a certain level above this inhibitory concentration, which we'll talk about in Form 1 later on, you're going to see that we can keep the bacteria from starting to replicate again. So if I give a drug every 24 hours, you may see that actually drop below that level and the bacteria start to grow. I don't want that. So maybe I give a drug more frequently, but at smaller doses to make sure I stay above that level, and then the bacteria don't have a chance to keep growing. Okay, so that would be an important concept when we talk about bugs and drugs later on in Farm 1. So kind of keep that in the back of your mind. But again, I can alter the dose and I can alter the interval because I can change that as a clinician. I can't change necessarily how the patient's clearing the drug, right? Maybe I can put them on dialysis, but if their liver's bad, I can't fix their liver necessarily, right? Necessarily give them a transplant, but I can easily affect things like the dose and the frequency. Okay. Any questions from the first half? All right, so again, we're talking about fixed versus fixed dose versus fixed interval. Again, this graph here is kind of showing similar to what we saw in the previous one, how I can alter the dose and give something at a larger dose but less frequently in order to get the same steady state concentration as something given a smaller dose but more frequently, right? Versus continuous infusion, which again not done as common as you would see with more kind of intermittent dosing. This picture here is kind of showing you what you would see with basically just a one-time fixed dose. So you notice here as I give a single dose, it will hit a Cmax, we'll get a level that's the peak essentially for that dose, but then you notice it's going to eventually trail off and eventually hit zero, right? It's only a single dose. However, if I were to continue with a fixed interval sort of dose here, you're going to notice that I'm giving another dose before the last one actually is fully metabolized, right? So again, there's still some leftover residual drug there, and that's why you're going to see these little peaks here that develop, and they get higher and higher until at a certain point I'm reaching that steady state, which again I'm putting the same amount in as I'm getting out of the system, essentially, right? And you're going to get an average steady state concentration, even though the peaks and the troughs are going to be kind of vacillating around that, essentially. Yes, ma'am. You could potentially, yeah. So especially when you're dealing with something where I'm giving a drug, say, less frequently but a much bigger dose, you could run into that sort of toxicity. You know, you could run into that. I'll actually tell you one example where we were shooting for that. So remember I mentioned the aminoglycosides, mentioned that we use those for like in the ICU for like really nasty gram-negative infections. And so that was a drug we used to use every 8 hours, you know, so basically you would end up running into something like this where we would give it every 8 hours and you see it eventually get to a steady state sort of concentration. But what we found is that a lot of people ended up running into issues, and when you'll find that especially that really sick ICU patients, their kidneys take a hit, right? I mentioned blood likes to go 2 places in the body primarily, and that's, well, to keep you alive. The heart and the brain, right? So oftentimes your kind of accessory organs kind of take a hit, and the kidneys happen to be one that take kind of a back seat there. So it's not uncommon for those patients who are really sick with those gram-negative infections to develop renal dysfunction, right? So what we were running into is that they'd have these renal dysfunction. All of a sudden the levels of the aminoglycosides would rise and actually cause ototoxicity. You actually find that it would damage the hair cells and cause hearing loss. And so the way we actually get around that nowadays, what we realize is what we can do is actually give one really big dose early on in the day, give a very large dose, gets a very high peak. However, the level drops down pretty precipitously after that, and by the time you give the next dose, the level's already zero. It's undetectable, essentially. And so we found that by having too high of an average concentration, that's what's leading to toxicity for those patients. So if we get it to a point where there basically is no steady state, we're just give a big fat dose early on, kill a bunch of bacteria, and then let it drop to zero, and then we give another dose, say, the next day, we got around a lot of that toxicity. That's one way we're trying to alter how we're dosing drugs in order to try to use the kinetics to our advantage, to where it can still be effective and kill the bacteria, but we're not going to be killing our patient as well. That makes sense? Maybe.
Then what would happen if we get to zero and the bugs are still there? Do they not grow back?
Yeah, so that's actually, again, beyond our scope. We'll talk about that extensively in Farm 1. There's something we call a post-antibiotic effect for some bacteria, or some antibacterials, where basically I can give them like one big large dose, and then even though the drug level drops to zero, the bacteria are still kind of shocked for a period of time before they actually can start growing again. And so even though the levels look negligible, they're still killing off the bacteria. So again, we'll talk about that more in Farm 1, but just know that's something that you may run into. So anyway. So we mentioned, some steady states can take a very long time in order to get to, because the half-lives of the drugs are so long. I mentioned amiodarone taking like 50 days. Half-life, it could take 250 days before you reach steady state. There's 4 to 5 half-lives to reach that. So what we can do is give what we call a loading dose. Anyone ever heard of a loading dose before? Basically, it's a very large dose that you're going to give early on. Usually the first dose you're going to give a very large loading dose to get them up to what their steady state should be. And then you start to give them intermittent doses after that to help maintain that steady state. So if I were to show you a graph of what this looks like, is basically you would have the loading dose in red here, and then you're going to have the continuous infusion that I administer following that bolus. And so amiodarone is a really good example, because this would be something that I would give, say, a patient having VFib, or ventricular fibrillation, who is basically coding at that point. If I can give them amiodarone to fix that arrhythmia, I want to keep those levels high to make sure they don't go back into that arrhythmia and start coding again. So what I do is I give a big loading dose up front, and even as that concentration starts to drop, as I'm metabolizing the drug, you're going to see that the continuous infusion is going to pick up the slack to where I maintain a very steady concentration within the body, right? So a loading dose helps me to get to steady state faster, and then I'm giving these maintenance doses afterwards in order to make sure I'm maintaining that steady state. That makes sense? And so you can see this with oral medications in some cases. Is anyone familiar with the Z-Pak? Right, a Z-Pak is basically, I don't know if anyone's ever taken one before, but basically you end up taking a double dose the first day, and then you take a single dose for the next 4 days. So it's a 5-day regimen there. That first dose is meant to be a loading dose to try to get your levels up high, and then those subsequent doses afterwards are maintaining that level at a good steady state concentration to kill off the bacteria. Okay, so again, that's why you may see some things have a large dose up front and then you use lower doses afterwards, is because it's a loading dose essentially to get you to steady state that much quicker. Make sense? Okay, other examples would be things like lidocaine for ventricular fibrillation, azithromycin. All those are good examples of using a loading dose early to get you up to steady state. Okay, so in those maintenance doses, we can figure out how much we need to maintain that steady state based on, we can rearrange things to figure out, what concentration we want, what is the clearance that the patient's experiencing, and then also our dosing interval. So again, we can figure out all these things to make sure we're maintaining a patient at the correct steady state and make sure they're going to be maintaining efficacy without developing a lot of toxicity, hopefully. Okay, here's another example of a drug we would give. I think this is clopidogrel. Plavix is another name for this. Anyone know what you use Plavix for? Yeah, I use it in patients who are getting stents for they're having an MI or something, and you go in and you have you send them to the cath lab and they have stents placed in to keep those coronary vessels open. You give them a drug called Plavix that prevents platelets from basically clotting up. And so you basically give several loading doses. You give several doses in order to get them up to steady state, and then afterwards you're giving them maintenance doses to help maintain that steady state concentration. That's kind of what you're looking at in this graph here. Okay. So again, knowing that the steady state concentration is equal to the dose divided by that clearance times the dosing interval, what are some reasons you think we can get super therapeutic or too high a concentration of drug in the system? What do you think could be some reasons why we might get too high levels? With
the loading dose?
Well, so just looking at these variables here, so what if I increase the dose? That could lead my concentration to be too high. So say, for instance, there's a dosing error and I'm giving too much drug to the patient. That could be one reason why the concentration is too high. Okay, maybe one thing. What else could I? What other issues could I run into? Okay, so if I decrease the dosing interval without taking into account the dose, I'm giving a drug more frequently without taking into account that dose. Now those levels, because that denominator is getting smaller, that CSS, that concentration is going to be getting higher, right? So that could be one thing. So maybe I should be giving a drug, say, every 12 hours. However, I'm giving it every 6 hours, right? That could be one reason why you may have the concentration being too high, okay? And what's kind of the third variable we can run into issues with? The clearance, right? So again, this is most frequently the biggest variable, or the thing that becomes most variable in our patients is the clearance. Because again, I can affect the dosing interval and I can affect the dose. I cannot affect the clearance in the patient for the most part. So again, if they end up developing like renal failure or they develop hepatic toxicity or something like that changes the clearance, makes it go down. If I don't change the dosing interval or the dose, then I'm going to end up seeing that concentration is going to go up pretty significantly. And again, we do this all the time, for instance, with neonatal patients who get transferred over to our hospital. Because again, we don't do any births at Nemours. We only get kind of the sick kids getting transferred over to us. And depending on how well developed or how premature those little infants are, we may have to give drugs every 12 hours, may have to give every 24, every 36 hours, every 48 hours. All depends on just how well developed they are. So we know that their clearance is variable. And so if I can change the dosing interval, then I can make sure that they get the right steady state concentration, right? It's just one example. We do this all the time, though, to make sure that we are making sure we're giving the dose at the right interval and at the right dose. Because again, when you're looking at those references and you're looking at, well, how do I change the dose based on their renal clearance, for instance, if they have renal dysfunction, one of the things you may see is it may either change how big of a dose you're giving, you may give a lower dose, or you may go, instead of giving something Q12 hours, you give it every 24 hours. That's kind of the most frequent thing you'll run into. Either change the interval or you change the dose you're administering. Okay. So anyway, so again, looking at absorption, sometimes this can affect how much dose actually gets into the system in the first place. So for instance, compliance is a big deal. So if you have, say, a too low of a level, you have to go back and see, well, is the patient actually taking the drug as they should be? So again, compliance is a big deal. Compliance is basically what? Yeah, is a patient taking the drug like they're supposed to? I mean, you can find all kinds of reasons why patients may not be compliant to a regimen. Either it's too complicated, or in some cases you may find, for instance, that like, patients who are very cost conscious, especially like older patients, you may say, hey, take this every 12 hours. You want to take this 2 times a day. And they're like, well, I can't really afford that. I'm only taking 1 time a day. And then hopefully just let it last out. And then when they come back to you and you say, well, are you taking it like I told you to? What do they say? Yeah, absolutely. We call it intelligent non-compliance, right? Because again, they're lying to you essentially. It's not out of malice, as it could be due to some other reason. But you're going like, well, the drug's not working like it should, so what do I need to do here? And you might change the regimen, even though that's not really the problem. The problem's the compliance there. And again, for a lot of my patients, especially tox patients, you know how I can tell if they're lying or not? Their lips are moving. It's usually a good way to tell. Anyway, there's other reasons you could have a poor absorption of drugs. So again, not just them not taking it, but if you have, say, impaired absorption due to, say, drug-drug interactions, drug-food interactions, this is a big one, especially if like patients are older patients drinking a lot of milk. Calcium tends to bind up a lot of drugs. That could be one issue. So again, patient education is super important. If they have a drug that interacts with grapefruit juice, tell them not to drink it. If it interacts with milk, tell them to separate it out by several hours. These are all things you're going to learn how to educate your patients on. From the clearance standpoint, again, this can be the thing that that is most variable and the thing that we have the least amount of control over for the most part. So whether it's the kidney, the liver, or the heart that are impaired here, we can't really do a whole lot about that. However, this is where we need to do more proactive drug dose adjustments, either changing the interval or changing the dose, or both in some circumstances. But again, this is very drug specific. You may, in some cases, you may decide, well, I have a patient who has really poor kidney function. Well, I'm not even going to use a drug that has to be renally eliminated in the first place. I'll use a different drug that goes through a different pathway. That may actually influence what drugs you use in a patient depending on what their organ function is. Okay, so looking at toxicities, again, we're looking at some causes we can develop some toxicities. Again, remember you can have some issues where you have identical receptors but in different tissues. You end up finding that there's a lot of side effects that don't really make sense based on the type of drug that you're giving. So for instance, with like opioids, if I'm giving this like for pain, for analgesia, I'm trying to help patients' pain, you may find that one of the biggest side effects you run into is due to constipation, or is constipation with these patients. And a lot of it has to do with opioid receptors being located kind of throughout the body, especially in the GI tract. So this is a big thing you're going to find a lot of opioid patients complaining of. A lot of times you have to give additional drugs just to overcome that. In some cases, you may find that have some toxicities that happen here via different types of receptors. A good example of this would be something like erythromycin. This is an antibiotic that we give occasionally. We don't really use it as an antibiotic much anymore. However, what we noticed is it actually works on different receptors, one called motilin, which we'll talk about in physio in the GI section, but it works on this receptor and actually increase peristalsis. Right? So increased peristalsis should do what to the GI tract? Should increase motility, which should increase defecation, right? So again, if we have patients who have like kind of impaired motility or impaired, especially constipation, sometimes you can give this to them. And again, it goes back to if I was using erythromycin as an antibiotic, what side effect do you expect to happen because of that? Probably diarrhea, right? So again, you can find diarrhea is a big side effect for a lot of medications, especially antibiotics, but that is a significant one related to erythromycin based on that mechanism there. Again, so some other reasons you could have super therapeutic concentration. Some of this could be due to intentional reasons. So again, abuse would be, what do you consider to be abuse? So I'm using the drug for some other purpose than what you prescribed it for. So for instance, you prescribe me Percocet for my pain, but then I'm taking it to get high, that would be considered abuse, right? Or if I'm using diuretics in order to lose weight or something like that, that would be considered abuse. That could be one reason why patients may have super therapeutic concentrations. Their levels might be too high. Could be attempted harm. So again, I deal with that quite frequently from the tox standpoint. People are trying to harm themselves. And then sometimes it could be unintentional. So we have children getting into medications, or if they have impaired clearance due to things like their age or their renal function, etc. I can tell you. So again, I'm a toxicologist. My wife is a pharmacist as well. You would think that we would have like the safest house possible to keep kids from getting into stuff. You would think wrong, because we've already had several near misses. And in fact, I had a recent scare just this past weekend. I used it as a cautionary tale, especially if any of you ever have kids, or if you have kids currently. We have my mother-in-law comes over, and she spends the night sometimes to help watch the kids and whatnot. And of course, older patients, they tend to be on several different medications. And so one day we were kind of going through and cleaning up the house and whatnot, and then all of a sudden we see this little tiny green pill located right on the nightstand, right in the room where she sleeps. And I'm like, what in the heck is that? Of course, I get very, very upset, because I'm like, I usually try to keep the house pretty well protected from toddlers, but unfortunately you realize that nothing is toddler proof. You can make it toddler resistant, but even that does not really work. And sure enough, it was a medication that had she taken that pill, even though it was a very small dose, it would have been an automatic ER visit. It would have been automatic, probably admission to watch her overnight. And it's one of those things where even if you do have the most, tightly locked up house, you can find they'll get into stuff anyway, right? And so this was an oversight, of my mother-in-law. Of course, we had a conversation with her, very stern conversation, and now she brings a lockbox to keep her stuff locked up. But again, it can happen to anyone. It's made me think, because we get all kinds of weird calls at the poison center. You're like, oh, how in the heck did this happen? It happens, right? Kids can really get into anything. So anyway, be very careful. Remember, everything can be poisonous in the right dose, right? Okay, and just remember, when you're dealing with toxicities, most things do not have an antidote. Most of the time is going to be the biggest thing that helps our patients, right? So we call it tincture of time, where you have to give it time for the body to metabolize the drugs off and get rid of it, essentially. And in the meantime, we're usually providing good supportive care. So again, we'll talk about tox stuff a little bit later on in Pharm 2. But just know that a lot of things do not have antidotes, and you just have to kind of weather out the storm, essentially, when you have patients that develop these issues here. Okay. So any questions about the end of this section here? If not, I will go into the next one. All right.